A very good evening, my beloved colleagues, those who already participated a little bit earlier. We are happy to see you here. Well, and it's our pleasure to introduce today's topics. Is very important as we named the session as review class. So this topic is not very new to you. You already got it through in your undergraduate life, postgraduate life. And we will discuss today very practical chest X-ray today. And intentionally, we will give the high attention for your exam as well. So with this word, we like to proceed. Please be with us. My humble introduction, our institute, moral alert, and later on the topics of chest X-ray review. It will be class 1 today, and later on any other day we will arrange the session, subsequent session on the X-ray relevant the topics. Before going there inside, I like to hear from you. Please, you understand that I feel a little bit better. Please, if you talk to me, any colleague, please just give me one question answer as general practitioners. What type of chest X-ray you are dealing in general? Please, anyone can say one or two like that. It will encourage me to continue. Dr. Kumar there, please.
Yeah, we are doing the X-ray, PA view.
PA view, special clinical diagnosis, not clinical, radiologic diagnosis and clinical scenario
Yeah. Mostly we are
commonly.
chest X-ray. Mostly we are doing.
Chest X-ray and you are dealing the cases, pneumonia. Okay.
Pneumonia.
Just
Correct,
tell me the
pneumonia.
name of the disease, pneumonia, then.
Pneumonia means the.
No, 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 no. No need to explain. Pneumonia, malignancy, lung cancer, pleural effusion, like that. You just mention few
Yeah,
name.
yeah. We already seen multiple X-ray pleural effusion also there, and sometime we seeing the X-ray for emphysema, and some
Okay.
consolidation patches also there.
Oh, sorry, Dr. Kumar, your voice is a little bit low. Maybe audio system is there. Dr. Taslima, please.
Assalamu alaikum, Dr. Usman.
Salam, please, Dr. Taslima. Very nice to see you. Just you can tell 1 minute only time. What common chest X-ray
So,
diseases we are dealing with in our general practice. Don't tell from a specialist angle.
yeah. So, more commonly we'll deal with mostly the pneumonia,
Okay.
then interstitial lung disease.
Yeah.
I think pneumonitis, and then yes, pleural effusion
Okay.
and consolidations.
Consolidation
Uh,
almost near about pneumonia, whatever you say. Then
yes, and
in the
TB
chest, tuberculosis is a clinical diagnosis or radiologic diagnosis from the chronic infectious disease. Okay. Any more
and
chest X-ray? Did you deal?
bronchiolitis
Bronchiolitis not much common.
for PED patients. I
Pet
think.
patient bronchiolitis not much. And how can you see in the chest X-ray bronchiolitis? Very common findings. You may not get it. Bronchial is a very terminal area.
Pleural
Anyway,
effusion.
pleural
Pleural
effusion.
effusion.
There are some other reasons of the pleural effusion.
Yeah, COPD.
Okay, COPD. Why you forgot COPD?
Yeah, COPD.
COPD, right? COPD. Can tell
COPD,
some disease from cardiovascular disease.
Yeah, that
cardiomegaly,
yes.
Cardio
and
cardiomegaly underlying there are some causes are there.
uh,
Okay.
Heart
yes,
failure. Heart
yes,
failure.
pericardial effusion.
Pericardial effusion means cardiomegaly indirectly in the radiology. Okay. There
Yes.
could be commonly GPs to face an acute emergency is the heart failure or left ventricular failure. Okay. These are the things. And
So,
there are
in case
some
of left ventricular failure, the finding will be the
in the lung,
enlarge,
in the lung,
enlarge, enlarge.
bed swing appearance,
Yes.
pulmonary edema, pulmonary
Pulmonary
edema.
edema.
Underlying,
Yes.
there are some other cardiac diseases as well. So our today, thank you for sharing. We are not actually taking your workshop or very strong, big enough time with us, and we are doing each and everything for the chest X-ray. Rather, we are here a little bit mature doctor, advanced doctor. We are seeing our patient. And so we will discuss the chest X-ray as a point of view as a professional that you are GP, not for the third year level. It is very, very true. So as we will give the highlights, important area of the AKT as well as the OSCE, I hope that all the candidates will get the benefit, no doubt. Even my junior colleagues or even any student today here, undergrad student, don't worry, you will get your required informations from our today's session. So with this few word, we like to proceed now. Just be with us. Dr. Taslima, may I request you, can you read the patient to us, please? Quickly.
Yeah, sure. A 58 years old male smoker presents with cough, mild fever, and unintentional weight loss for 6 weeks. Chest X-ray shown. What is the most likely diagnosis?
Very right, very right. And this is, I told you, we designed the presentation compatible for OSCE as well as AKT. And Dr. Taslima and all of you understood that this type of presentation compatible for OSCE or AKT. This question in this way, without showing options. This is OSCE relevant discussion by this. I like to hear from you what the most likely diagnosis with these salient features from the history. What could it be? Any colleague? Dr. Sharma.
Tuberculosis.
Tuberculosis, 6 weeks.
The age is 58 years. So age is more than
Okay.
55 and smoker, unintentional weight
So,
loss for
do
6.
you like to add any other diagnosis other than tuberculosis?
Consolidation. So
Consolidation is a
lung
radiologic
cancer.
diagnosis, but
Lung
underlying disease,
Lung cancer.
lung cancer, okay. Because background is the smoker for that.
Age and
Age
smoker
also, right?
and
Could
weight
be,
loss.
could be,
But
could be. Any other colleague to add? Dr. Mahsin, Rashid, quickly, please. Dr.
So
Mahsin,
it
Rashid.
looks like, yeah, it looks like consolidation related to some tumor
Tumor.
or
Tumor means
maybe
malignancy,
em-
lung cancer. Then
malignancy.
an
It cannot be
infection.
some emphysema, cannot be, it doesn't go with the infection.
Infection could be chronic infection, doctor. Some colleague opined as it could be
Yes.
tuberculosis. What do you think?
No, tuberculosis is always on the upper lobes. It cannot be tuberculosis.
Sorry, doctor, to say choosing the word is important. Not use the word always, always. Yes, very common
Okay.
site is here. Very common site is here, but it can happen in these areas, especially in the South Asian, because we are endemic. We are in the endemic zone. So if you think about the chronic infectious disease, it could be even the tuberculosis. Okay.
Okay.
Let's see. Let's see.
Yes.
Thank you very much for your joining. And OSCE candidate will proceed further with your diagnosis and further management. You will do. Now, choose your answer, please. Especially inviting the AKT candidate. I know many colleagues today actually went to the other side of the river today. You are no more AKT candidate now. We will enjoy it and we will feel our pleasure, share the pleasure later. But any new beginner, rather to say AKT candidate, who will answer from here? 5 options are there. Quickly, any AKT colleague, please. Dr. Sharmin, yeah.
The right middle lobe collapse due to obstructive bronchial carcinoma.
Pneumoma. So underlying is malignancy and the white area is the collapse. So what is the point in favor to say collapse? There should be mediastinal shifting. I'm just prompting you. Is there any features of mediastinal shifting? Quickly, Dr. Sharmin. Anybody, please share. Any features of collapse in that means that I just prompted mediastinal shifting. Is there any feature? Intentionally staying with the fast X-ray a little more. Dr. Taslima and other, why not telling? What about the position of the trachea? Is it in the midline?
Slightly deviated
deviation to
towards the
the
right side.
Right side. Usually it
right
is
side.
right side, but if it is significant, we can consider if how to say this is shifted to the right. if you can go through in the YouTube, the technical adequacy of the chest X-ray. This is another discussion you will follow there. But if you look at the spine should be in the middle, right? And trachea overlying the spine, more a little to the right. It is true. And we have to say other thing also is the position of the patient is correct or not. The spine should be equidistant from the ends of the clavicle. Then you can consider or perfectly identify the position of the trachea. I just added up to these. Even then, if you become confused, you will come to the heart. Dr. Sharmin, look at the 1/3 of the heart towards the right side, 2/3 in the left side from the midline. Just apparently. So everybody look at, are you more confident that trachea shifted towards the right? Then you can say, though there are some other features of that pulling of the diaphragm above like that, some advanced, very chronic type of collapse can show something else, traction of, if there is fibrosis, especially in the advanced candidate, advanced patient. So more likely it is, Dr. Taslima said is a malignancy. I think you are telling in this way, Dr. Taslima, is a malignancy and causing the pressure effect and lung tissue collapse. This is the explanation.
Yes, doctor.
Before going to the answer, this is the wedge-shaped opacity in the right middle zone. Loss of right heart border. Border means complete heart border is not visible. So if it is the whatever the cause of the consolidation, there are something more we are learning already. You have learned it. We have to say this is middle lobe involvement. Okay. What is the name of the sign? Very popular word. What is the name of the sign? Silhouette sign.
Silhouette sign.
Silhouette
Yes.
sign. Silhouette sign. If silhouette sign it is there, it is more likely that middle lobe is involved.
Okay.
So disease is not in the middle lobe, rather disease in the bronchial tree. Okay. There may be endobronchial malignancy also, or malignancy surrounding the middle lobe and compressing the middle lobe or the airway. Then patient develop more likely to be the collapse. So compare the two features. This is the question and this is here. And come to the answer now. Right middle lobe collapse due to obstructing bronchial carcinoma. I think this explanation is enough for you. Okay, if any colleague have any question, we will stay here. Otherwise, we will jump. Doctor, anyone to add anything? Nothing. Dr. Taslima, to ask anything?
No, it's clear.
Thank you very much. Thank you very much. And coming to the next patient, Dr. Taslima, can we continue with this second patient, please?
Yeah, sure.
And other colleague, please, other colleague, feel free to talk to the session and keep your hand raising in the system, please, in the Zoom, so that I can easily invite you. Dr. Taslima, please carry on.
A 32 years old man has a cough for 5 weeks, night sweats, weight loss, and low-grade fever. Chest X-ray shown. So most likely diagnosis.
Okay, tell the diagnosis, any colleague. Dr. Mohsin.
Sir, this
It's
time
tuberculosis.
tuberculosis.
Tuberculosis, you're telling etiology
Yes, sir.
diagnosis. Is easier X-ray rather than from before?
Yes, very easy.
I ask you now, is it tuberculosis of the right lung or left lung?
Sir, right
It's
lung.
right.
Right lung? Okay, Dr. Mohsin.
It looks both lungs are
Sir,
involved.
both lungs are involved.
Dr. Sharman, you opened your eyes very lately. Why you are busy with that? Both lungs are affected.
Yes,
Okay.
sir.
But very significant feature in the right side, and Dr. Colleague, maybe Dr. Kumar added possibly before, or Dr. Mohsin maybe. Apical area you mentioned, right, Dr. Mohsin Rashid?
Right side
Yes,
at
yes.
Yes.
massive fibrosis at
Cavitation. In South
cavitation.
Asian patient, it is unlikely to be other than tuberculosis. But okay, again, if Dr. Taslima said in the clinical background, smoker, advanced age, significant weight loss, it may be the malignancy also. But bilateral malignancy is unusual. Okay, rather bilateral
Yes, sir.
tuberculosis is more likely. So underlying, I think our AKT colleagues, what will you choose here? Pulmonary tuberculosis.
Pulmonary
Yes, sir.
tuberculosis.
Let's go. Let's go. So cavity relation, upper lobe in the both lung, especially in the right apical region, there is a cavity relation. Cavity relation and pulmonary tuberculosis. Is there any complication of tuberculosis in the chest X-ray? Can anybody identify? If not, please tell me, especially OSCE candidate, what could we expect the complication of tuberculosis could happen in the chest X-ray? X-ray in
Pleural
the,
effusion.
yes, pleural effusion, and why not fibrosis, doctor, later on? It is very advanced tuberculosis. Okay? Tuberculosis is not malignancy. It can stay a long time. So there is a chance of fibrosis later. Could be fibrosis like collapse feature. So malignancy present with the collapse. Remember, tuberculosis can present with fibrosis. X-ray appearance near about almost same, but not 100% same. Okay, doctor? Thank you. So now for the OSCE, a lot of things you need to know about the tuberculosis. But for AKT, for this question, you must identify the appearance of the X-ray. So Dr. Taslima and other who told me before, just observe that you have said the common X-ray in our general practice. Hopefully, we will try our best to give you touches from all the diseases today. Okay. Next one, may I invite other than Dr. Taslima, please, Dr. Masin Rashid, maybe, if possible, can you go with the patient? Can you
Yeah, it's
describe the
three.
patient, please?
Question number 3. A 67-year-old male smoker was treated for pneumonia 6 weeks ago. He feels slightly better but still have cough and weight loss. Repeat chest X-ray shown.
Shown.
Best next step.
That means I like to explain it. Repeat chest X-ray as before. There is
X6.
no,
Yeah.
that means not improvement, no improvement. Okay?
Yes.
No improvement. So clinically, we have to say it is the causes other than pneumonia. It is called non-resolved pneumonia, non-resolving pneumonia. Though pneumonia could be one of the cause of non-resolving for some reason, but in general, it may not be pneumonia. It may be other than pneumonia. This is the thing. Okay, Dr.
Yes,
Mohsin?
sir.
And it should be
Yes, sir.
understood
Yes,
by
sir.
the OSCE candidate. And AKT also for you, I'm showing you now. Better Dr. Mohsin or any other colleague can tell. What will you do now? Management part.
HRCT.
Dr. Taslima will do, Dr. Mohsin, Dr. Aisha, Mubashir. Try
Repeat
to
the
talk.
X-ray.
Don't mind. We'll mind. Rather happy. HRCT.
Yes, sir.
We will
HRCT.
repeat the X-ray.
HRCT. What will be your intention to do HRCT? Identify what? What HRCT can help here? Already X-ray is very grossly visible something there. We need to identify the reason of the disease more likely. I'm not prompting positively, negatively. I'm just thinking. Dr. Anuja,
We'll do the sputum cultures
sputum culture for what purpose?
to see maybe there is antibiotic resistance.
Okay, very right. I agree. I appreciate. So other cause? Only sputum for
And
infection.
no, it's typical pneumonia. So
Choose
we'll
from
do
here, doctor.
see.
Don't take more time. More time. From there.
C.
C. Urgent CT, suspected lung cancer referral.
Urgent CT chest.
Okay. You are thinking it could be malignancy. What is the reason behind to think of it?
Because despite of
No, this is one is the
Weight loss.
non-resolving. What other thing? Dr. Taslima's answer as before. 67-year smoker.
Cough
yeah,
and weight loss.
Weight loss. Weight loss can happen in
Weight loss.
tuberculosis also. Any chronic disease can cause weight loss. But whenever weight loss is very
And
significant.
patient is smoker also, sir.
Yes. So you are thinking malignancy. Urgent CT chest and
Suspected lung
lung
cancer.
cancer. You will send to the malignancy. Okay. But what Dr. Anushya said, I appreciate as you will go with the CT scan also, or it is also justified, but checking for resistant organism, as you have given the antibiotic before, even the exclusion of the tuberculosis is also important. Do you agree, Dr. Mohsin and other? Because
yes, sir. Yes, sir.
you see features in the apical part.
Yes, sir, we can see that.
So you have to think as OSCE candidate. Remember, your answer may be best of 5 or SBA could be 1 there, but it is not in the OSCE. OSCE is a composite. So persistent right upper lobe consolidation despite antibiotic. This is the difference from the picture. And right hilum partially obscured. Obscured, if you can identify obscured means infection or malignancy, doctor. Whenever the airway is obscured, more likely underlying cause is malignancy or infection.
Malignancy.
Malignancy. Malignancy. I told you endobronchial growth is there. Endobronchial growth. But Dr. Taslima, is it easy to identify that airway is blocked here? Easily as a GP? Not easy. Not easy.
Yes.
If we are too much competent in radiology, then you can tell. But again, the previous one, if you compare the collapse, whenever bronchus is obscured, there is in features of collapse. Okay? If you identify any features of collapse there, then you might be able to identify the obstruction in the bronchial tree. This is a secondary observation. Anyway, so more likely will be here urgency and suspected lung cancer referral. We don't have enough time. Whenever we suspect malignancy, better not to try. Okay, Dr. Anuja, you are also right. You are also right. I appreciate you. But I was not happy that you just focus only infection for the sputum. Why not in the sputum you could include malignant cell? Minimum, doctor.
Yes.
As you collect the sputum, why not all the tests could be done in the sputum? Why should we wait? Malignant cell, even the resistance organism also. If you think about the any interstitial lung disease in different type of X-ray, you could identify even eosinophils there. Many immunologic tests. You know about the what is called collection of the sample from after the bronchoscopy. Who can say this name? BAL. Bronchoalveolar lavage.
Bronchial,
Bronchoalveolar lavage could be, but this picture is that much gross that even from the surface doing the CT scan, CT guided actually biopsy could be possible. Okay. The answer could be a little bit different also. CT guided biopsy also possible here. Anyway, finally, the best answer will be urgent CT scan and the referral. Okay. Because it's
Dr. Usman, I have a confusion.
please,
I have a query.
please.
So, like in OSCE, if this kind of X-ray is given, and I am suspecting that it could be lung cancer.
Yes.
So, in that situation, should we tell the patient that I'm suspecting you are having lung cancer, and I'm refer you to the specialist for HRCT and to confirm the diagnosis like this, or how we can how we'll manage the patient in that scenario?
Manage is the referral, straightforward. But how to say? Rather, ask
Yes.
me how to
Is it
communicate
breaking?
to the patient.
Yes.
This is the way. This is the learning of practice session. But the message will be in a way that I am suspecting some growth there. Okay, it could be a naughty disease. Understand? Before confirming the cancer, you better not utter the word cancer. Understand? You are not 100% right. You are suspecting. So other than cancer, you can use different wording. Growth, naughty disease, something bad. Understand my point?
Okay. So we can tell like it's a growth
Yes, growth or naughty disease. Naughty disease.
or
But
something serious or
again,
something
I
suspicious.
like to say the final word. No need to go further. If patient asks the doctor, is it cancer? Then what will you say? Dr. Oski colleague, please.
I will say that right now I cannot say it's a cancer, but I am suspecting something. There is a suspicious mark which I need the confirmation from the specialist.
But you cannot deny this, that it is not cancer. You cannot say. You have to be very tricky, rather to say diplomatic in the answer. What Dr. Anushya tried. If I ask you, the doctor, this is cancer, so answer will be I am not sure right now. What does it mean? I am not sure right now. It doesn't mean that I am excluding. Could be possible in this way. Okay, doctor? I'm
Yes.
not sure right now. Up to this enough, Dr. Taslima. I think you are happy now to
Yes.
say. Let's
Yes.
see. Let's see. In any cancer, doctor, not only the lung cancer, anywhere, until I get the confirmed result, better not to use the word cancer. Okay? Remember it. In the OSCE session, we will try our best how to say in the breaking bad news station. This is a separate class. And I think our AKT colleague also understood, identify the chest X-ray, how to identify a suspected lung cancer. I will be very happy if any AKT candidate talk to us. Thank you. Now, again, may I go to Dr. Mohsin, please.
This is a 61-year-old woman presents with progressive breathlessness and weight loss. Chest X-ray has shown most appropriate initial investigation.
Answer, please. Answer, please. Dr. Aisha Mubashir talking nothing today. Everybody try to talk a little. Dr. Mohsin, you can answer also. Why you stop? You are the volunteer today.
So it looks like some pleural effusion.
Okay.
So initial investigation, I mean, already it's an initial investigation is the X-ray which has been done already.
Okay, then what will be the
Is
next?
fibrosis, pulmonary
No.
fibrosis.
Question is that already you have done the X-ray, you found the picture. What will you do now after that? Initial means the next investigation. Is there any clue that this is tuberculosis? This is malignancy? This is parapneumonic? Nothing there. Okay?
Yes,
Doctor,
sir.
if I ask you, Dr. Taslima, you are advanced.
Uh,
Is there any
weight
features of
loss is
collapse?
there.
Doctor, I just tell you, though it may take long time, don't mind, because this is a learning session. If it is a malignant case, for example, 61-year-old woman might be, what I say, smoker or whatever. If it is a malignancy, what other feature we could expect in the X-ray? Malignancy also can cause this type of huge effusion. What we could expect here? I'm just discussing a little advance. Those who want to take part in the discussion, you are welcome. Dr. Anushya.
Any mass?
Dr. Maz, you cannot see. Maz will be hidden under the water.
Okay, have this.
Under the water.
Trachea is not shifted, but there
Who is talking? Who is
no
talking, Dr.
problem.
Adnan? Who is
Sir,
talking
I mean,
trachea
Dr.
about?
Adnan,
Dr.
sir.
Adnan?
Trachea shifting.
Trachea
Yes,
now
yes,
Correct.
yes,
despite
yes.
new situation.
Thank you very much.
So
That
there
is
might be
expected to be
collapse
seen.
region.
Features of the
Yes.
collapse in the underlying water rather. You may not see this collapse. You are looking at the water. This is very intelligent answer because trachea is visible to you. So expand your X-ray, doctor. I hope that it will be benefit for today's discussion with you. Okay, try to be with us. Anyway, so doctor, now come to Dr. Mohsin, who with the courtesy actually presented the case. What next investigation could be? Dr. Taslima?
Hello, sir.
Yeah,
Hello,
doctor.
sir.
Sorry, you may not mention your name. You are doctor only.
Yeah. I am Dr. Atiya. Basically, sir, I want to ask you as
Yes, Dr. Atiya.
there is a unilateral large massive effusion. Yeah, there is a unilateral pleural effusion is showing, and I am seeing that there is a meniscus sign as well, and noticing that this is a mediastinal shift as well. Look like. So, sir, what you were
It could be.
explaining,
You
I
raise very technical
missed
issue,
that
doctor.
part.
I am very happy to hear. The X-ray will be complicated. That there is a collapse is pulling, malignancy is pushing. Trachea may not be shifted.
Exactly. Okay. Thank you, sir.
Remember it. It is an extraordinary. Actually, you were discuss. I don't know. Did you
Sir,
have a
I was
rendition of
little bit.
MRCP? It's a MRCP part 2 question you ask me now. Part 2, MRCP part 2 written. Thank you, doctor. So better not to go in depth too much. What we discussed, we learned a lot. Dr. Litton is here also to tell about.
Okay, sir. I will go for further investigation such as floor
Pleural.
fluid aspiration.
Let's see. Okay, no need to discuss further, Dr. Litton. Let's
Yes,
see the option.
pleural fluid aspiration.
Choose the best option, Dr. Mohsin. Look at please, everybody. Doctor.
So
Option B.
diagnostic pleural aspiration with fluid analysis.
Fluid analysis. I think so, but large unilateral pleural effusion of the meniscus sign. Okay, blunting. This is this you know about the features of effusion, no need to say. So if any undergraduate student also, they will be more happy to know the radiologic feature. For this reason, I have added separately. This is the difference, okay, with the labeling and come there. Trachea and mediastinum shifted to the little left, they are telling. Trachea a little left, but not much clear, I understand. Some pushing effect are there. So some pushing means pushing due to pleural effusion. Malignancy underlying could be there also. Because 61-year lady, is it? If smoking is
Yes, sir.
there, we will be more near the diagnosis. So diagnostic effusion and the fluid analysis. Now question is, fluid analysis means asking to OSCE candidate again, what component you will write in the fluid that it needs to be tested? Dr. Litton. Dr. Litton is very today in the OSCE group, right, Dr. Litton? From
Yes.
today. From
Thank you.
today, you are in the OSCE group. You tell me this blood fluid analysis you like to do.
So initially, I will go for cell count. Pleural fluid for malignant cell.
Malignant cell, then.
And pleural fluid.
Sorry, Dr. Litton,
ATA.
for you, your voice not clear. Your voice not clear.
Sir,
Maybe interrupt.
I'm right now outside.
Outside, okay. Sorry, Dr. Taslima. Dr. Taslima. Dr. Adnan also can join. What test you like to do?
The pleural fluid aspiration for
Already
gram
done,
stain.
Dr. Pleural fluid. You have to write in the prescription. You are testing this for the pleural fluid.
Yes,
First of all, you
TB,
can tell
gram
the
stain.
biochemical test.
Yes, the
Why
gram
not
stain and
biochemical
TB.
test? First
Biochemical.
biochemistry, then. Sorry, Dr. Taslima, I always my habit to loud, to be
No.
loud. Huh? Sorry.
Biochemical test for
Okay.
malignant
Cell.
malignant cells, TB,
Then
and
TB means FB or
FB.
gene expert as well.
Gene expert.
Though we are thinking it could be malignancy, even it could be other than malignancy also. For this reason, we will not focus only for one disease. This is the idea to share with you. Okay, though it could be malignancy, but don't focus only one disease in the study. Otherwise, you need to collect the pleural fluid again and again. So for OSCE candidate, you have to expand your horizon of understanding underlying etiology about. Accordingly, you have to say that I will test the fluid for this is more likely. I'm thinking
Sir.
about. Yes, doctor
Sir, yeah.
again, sorry.
Atiya,
I remember
sir.
one other Atiya from Pakistan. I think you were new Atiya to us. Please, doctor.
Sir, I'm also from Pakistan, but this is the first time I have joined.
Oh,
Yeah.
I
Sir,
remember
this is
our
first time I
Atiya.
have joined your class, and I'm also
Right, doctor. I remember the Atiya.
so.
Okay, please add your comment.
Yeah, sir. I will be writing on the prescription like I want to check pleural fluid analysis for the protein LDH, for glucose cytology, gram staining, and the culture as well.
Gram
and
stain,
AFB smear as
culture,
well.
AFB, malignant cell.
ADF.
Malignant cell. Yes.
AFB, rather to say nowadays in South Asian country, gene expert, there is a PCR is very available. Okay, PCR is available.
And sir, ADA levels, because I used to write that as well.
ADA definitely, ADA very important in this. ADA. So all the things, it should be your composite further investigation part for the OSCE. Be sure about. Okay, don't only make your vision tunnel. Thank you, doctor. Thank you very much. Already these are discussed down. And now come to the next. Dr. Atiya, please. We invite you already. Dr. Atiya, join with us. Discuss the patient to us. The 45-year. Dr. Atiya, where you are, can you open the mic? Otherwise, may I invite Dr. Adnan, please. Dr. Adnan with us? Are you busy in the chamber or somewhere? Dr. Adnan.
Yeah.
Dr. Atiya
Hello,
here.
sir.
Sorry, Dr. Adnan. Dr. Atiya, please.
Yes, sir. Sir, this is a case of a patient.
No, you just read it for us first.
45-year-old woman. Okay. 45-year-old woman has fever, productive cough, pleuritic pain, chest X-ray, shown here, respiratory rate of 20, blood pressure normal, alert, age is less than 65, no comorbidity, best management.
What will you do now in your chamber? Many information given in very
Sir,
short
I will be,
words.
sir, curb scoring I would be checking, and it is like 0 to 1 here. So
Doctor,
oral
carb
antibiotics I
scoring
would
is
be preferring.
very technical word you have used. But by look to the patient, what could be the carb score? Could we guess? If it is possible, could we treat? It is also another question. Don't tell everything from the book. Sorry, doctor, I may not be right. I'm just telling. Definitely, if we see such patient, more likely everybody thinking there is a consolidation, or it could be even the pleural effusion, less fluid could be there, like that. 45-year-old, less likely to be malignant. Background is not for the malignancy, but pleuritic pain. It means pleural involvement is there. Maybe parietal pleura is involved. Productive cough, it could be infection. How many days? Maybe acute disease. Duration not mentioned. So it may be infectious disease, acute infection. Okay. If it is so, will you do carb 65 before carb 65? Could we do anything? But carb 65 is a clinical weapon. We can utilize very easily, no doubt. What could be expected in the carb 65 by looking the clinical background? More or less?
Less. 0 to 1 is good.
Less. Now come
Less.
to the options. Is there any option of carb 65? Dr. Atia?
No, sir.
No.
Oral antibiotics.
No. I'm just telling the technique, doctor. Why I discuss it a little more. In the AKT, option of carb 65 is not there. It means you have to think of action. What will you do now? Okay. That I mentioned, don't tell everything from the book. Okay. So now what the best management action here? Any colleague now join?
B looks better. Oral antibiotic safety net review, usually 5 days if stable.
If stable means, is your patient stable now? Relatively stable. Hemodynamically good.
Yeah.
No comorbidity.
Yeah, BP. Yes.
So I think it could be one option. Any other option who want to say? Different option other than B. Already one colleague commented this is B. Other colleague, can other colleague say other than B?
Sir, immediate CT chest.
Immediate CT chest is a very cheaper doctor for your countryman. You are in the rich country for that. Then, and CT we will show you the underlying picture of there is a fox or tiger or something else. Right, Dr. Sharmin? Dr. Taslima telling nothing.
So my option is B, doctor.
B. Oh, B. So radiologic diagnosis, especially the undergraduate information, rather is a lobar consolidation in the right lower zone. Okay, carb 65 in general procedure, but in the action plan, as there is no other thing, oral antibiotic safety net review, usually 5 days. Usually 5 days means keep in your mind for any acute infectious disease, even in the OSCE exam, 3 to 4 days later, you must follow the patient up after any infectious disease, acute infectious disease in general. It could be viral, it could be bacterial, whatever. After 3 to 4 disease in our general practice. So 5 days is a reasonable option. Hopefully all of you understood. Thank you. So Dr. Ati again, this your second patient, our sixth patient. Dr. Ati not possible. Dr. Adnan. Dr. Adnan, please. Dr. Ati might be busy. Dr. Adnan, please.
Yes, sir.
Yes.
70-year-old man presents with fever, confusion, and respiratory rate 34 per minute. Blood pressure 88 over 56 millimeter of mercury, and chest X-ray shown. What is the best management?
Best management they are asking.
Admit the
Hospitalization.
patient.
Hospitalization.
Hospital admission.
Hospital, because you are very worried about the chest X-ray by looking there. Something very dangerous inside the chest, nothing there on other than white area, very regular.
No, and
Patient
carb
is
score also
hemodynamically
high.
unstable and confusion, features of shock
Carb
there.
score is also high.
That means
That
we can
low
expect the
aspirated
carb
rate
score
high.
more here. Is it for that? So I
Yes,
will
sir.
do carb score. Actually, it is not your management. Remember it, right? It is your clinical evaluation for further action. So carb score will not be your action plan. Carb score, like you are measuring the blood pressure, it's the similar thing. Understand, Dr. Adnan and other? Carb
Yes,
score
sir.
is not the answer that I will do the carb score. It could be undergraduate question. Carb score is my evaluation process. After completing the evaluation in any consolidation, then I will decide. So our decision is maybe B, you are telling B.
B.
Yes.
Yes, sir. B.
Yes, sir. Yes,
There
sir.
is
B.
septic shock.
Multilobar consolidation. It could be shock also. But blood pressure, yes, it's a very shock
Yes,
statement
sir.
about.
Sure.
Septic
It could be
shock, sir. It
sepsis.
seems
More
like
likely,
septic
it
shock.
could be sepsis because blood pressure is very low,
Respiratory rate.
Aspirated rate
and
high.
patient is very vulnerable. 76 years.
76.
Carb 65, more than 65, one score. Other thing, many scores are there. Good, doctor. Thank you. These are the X-ray and other doctor in the AKT. Don't worry. And I think you are being happy. Don't be confused with the very. So thank you, Dr. Adnan, as well. Who will come forward to read again, Dr. Masin?
A
Dr. Masin.
22-year-old tall,
Yeah.
thin man present with sudden pleuritic chest pain. He is
Okay.
stable, saturating 98%, minimal breathlessness, chest X-ray shown, best management.
Try to identify the X-ray diagnosis. I like to say this question a little bit complicated for you. They didn't mention about the chest pain in the which side. It is easy to get, right? Patient could tell chest pain in the left side or chest pain in the right side. I'm sorry, I couldn't add it. Just adding for you, chest pain in the left side.
Mhm.
Try to identify now.
So, sir, pneumothorax.
Pneumothorax.
Pneumothorax, upper
Air
Pneumothorax.
under diaphragm,
If it is a
air under
pneumothorax,
diaphragm is there.
Pneumothorax.
So maybe
Yes.
some perforation is there.
or you are telling
No,
in
Perforation.
the
this this
pneumo-abdomen,
no
doctor, or
no
pneumoperitoneum.
this is
This is
stomach
funny
bubble.
guess.
This is a funny guess, doctor.
Funny guess.
If the left side
Sir,
pneumothorax, you are
uh,
meaning that air is there, air is here. Very difficult to
No,
say, right?
this is
Very difficult
collapse
to
actually.
say. Difficult to say. Let's see now. What actually, if it is a pneumothorax, what will you do?
So we put a chest tube.
Sir, observe the patient first, initially conservative, like giving analgesia, some observing the patient, like as he is maintaining oxygen saturation 98.
Sorry, Dr. Atia, couldn't hear in between. Dr. Atia, are you OSCE candidate?
Yes, sir.
You're sounding like this. Very right. Dr. Atia, can you tell me in the X-ray, if it is a pneumothorax, patient presented with the left-sided chest pain, can you say that in the chest, in the left side, there could be air, maybe in the apical area, right? Maybe in the apical area. So if you are not confident enough by looking in the chest, but how you are again being a little confident by looking where?
Because sir, there is a I'm seeing that lung markings are absent.
Doctor, be away from the
uh,
lung marking. I think Dr. Taslima, other colleague could tell that, oh, there is no loss of lung markings. Somebody will argue. Yes, yes.
Sir,
Yes.
the patient is 22-year-old, tall, thin. This kind of patient, this age group come with a little, pruritic chest pain, breathlessness. So the
Marfan's connective
Marfan
tissue
syndrome.
normal,
So
abnormalities.
So you are thinking the diagnosis today from the background disease. It could be one of the clue,
Yes,
but
sir.
it is not a strong clue. In the radiology, in the X-ray, tell the radiologic feature. Somebody, I think Dr. Adnan said, someone that there is a pushing effect.
There is some pushing effect. There is
Why you are not
yes, trachea is
identifying pushing
deviated to the right.
effect? You could identify clinically also. There isn't by right now the pointing with the index finger. Check the trachea. This is the way. This is the way the clinician's view in this way. Not that I may get clearly in the focused area, but I can get some circumstance. Your clinical identification is very right, but in the radiology also it is possible. Okay. And there
But
could
sir, here I'm not appreciating any mediastinal shift, or I'm not
very difficult. For this reason, I'm telling very difficult.
identifying.
But
Huh.
your clinical examination will be the best one here. What will you do? Inspection, palpation, percussion, auscultation.
Exactly, sir. Yes.
What clinical clue will rather give you more information, valuable?
Percussion.
Percussion. What will be the percussion note?
Resonant, sir.
Resonant.
Resonant.
Hyper-resonant.
In my sense, it will be the best clinical feature here. Even you are confused in the X-ray, but your hand, your finger will tell you this is pneumothorax. Okay, this is the clinical efficiency. And chest will be silent there, rather less moving and resonant. It is the air. Okay, chest not moving well. Chest not moving well, it is dull there. It is a pleural effusion, especially in the lower part of the chest. If it is the upper part, chest not moving, but resonance, this is air, pneumothorax. This is some clinical tips. So best management now. Someone tell that I will give chest tube. Possibly someone will not. Dr. Adnan, Dr. Atia, what is your answer?
Sir, B.
Sir, because patient hemodynamics is okay at the moment, so I would like to manage the conservatively at the moment, like giving
B.
analgesia.
Dr. Taslima, Dr. Taslima.
B.
Dr. Azra, new colleague
Yes, sir,
open
B.
now.
Sir, I have managed the same patient.
Oh,
Yes, sir.
that's
I
good.
did the
But
same.
doctor, you have done doesn't mean that you are correct. Sorry, sir. It should be correct in the exam.
No,
Remember it. Okay.
no, sir. At that time, I just managed it consecutively.
Very right. Very right. Dr. Adnan, what do you tell? So this is the left apical pneumothorax. This is a very challenging X-ray. This is very challenging X-ray. I like to add you something. One radiology question. It is called, what are the reasons of apparently normal looking chest X-ray? Remember it. It's a postgraduate question. Remember it. I repeat the question. What are the causes of apparently normal looking chest X-ray? It means actually it is not normal, but not easily visible. This is one of the X-ray. Clear? Apical pneumothorax, small apical pneumothorax. Okay, doctor. Okay, doctor. Conservative management. As hemodynamically stable, and there is no shifting of trachea too much, though you think that a little trachea shifting, but somebody will argue again. Trachea naturally be like this. Okay, naturally be like this. Thanking you. Are you becoming tired? Dr. Gayatri is here today. Are you becoming tired? Any relevant question, doctor? What we discussed till now? We have some few more patients also. Up to this, any question in your mind? Dr. Shoaib also here. Welcome, Dr. Shoaib. Very nice to
Thank
hear.
you very much. I've just joined.
Dr. Shoaib, congratulations.
Thank you. Which say?
It's a time to congratulate. Let us congratulate you.
Thank you. Thank you very much.
Very happy to hear you. A little
Muslima.
later
Oh,
part,
acha.
little later of the session. Let us finish your radiology, and we like to hear from all the colleagues from Dr. Shoaib and others. No problem.
Sure.
But
Inshallah.
actually, I expected some colleague will tell about the chest X-ray, and really, we are very happy to know for today's
Dr.
news.
Osman, I have a question.
Please.
Like the pleural effusion and pneumothorax, this kind of what is the ratio to have this kind of X-ray in the OSCE?
Pneumothorax is less, rather pleural effusion will be more because easily diagnosable situation. Pneumothorax is a next one, especially this type of X-ray. I think, doctor, I just don't mind. I'm just believing myself as a trainer for you, nothing else. Okay. So when a trainer, doctor, let me finish. When a trainer chooses the topics, usually a trainer is to choose a complicated one.
Yes.
To learn more. This is the fact. Otherwise, in the X-ray of the OSCE, actually, they are very clearly visible air without the lung, the bronchovascular marking with a clean cut lung margin. Okay, so don't be
Okay.
confused about this. It will be very easy for you. This type of X-ray almost equally available like the effusion as well as the pneumothorax, but clinical clue is very important by the tracheal shifting with the percussion note.
So, sir, what I want to know, like in the OSCE station, if SP gives me, okay, I'm having the symptoms and I have done the chest X-ray and this is my report, and I
Yes.
saw that okay, it's a pleural effusions, and the SP must be given some clue. So then I have to, search the DD of the
Yes,
effusion, and then I
definitely.
have to manage the patient, give the investigations. So then. I can't give any definite, diagnosis. So,
Definitely, you cannot give any definitely diagnosis there.
so then what will be my approach to
Approach will
manage?
be you will plan for investigation, okay,
Mhm.
and then tell the patient come back with the reports.
Okay, it could be TB, it could be,
Patient will ask you automatically, doctor, what it could be.
okay.
Okay, usually if time is there, better you have to keep some time. Always in the OSCE, you can remember option could be that do you like to add anything more? Do you like to ask anything more? It should be there to the surrogate. Surrogate there could ask you the doctor, what is the reason of fluid there, water there? You tell few possible 3 or 4 diagnoses underlying possible, but you cannot tell this is for the tuberculosis, it is for the malignancy. Okay.
So my approach will be differential approach.
Differentials, definitely differentials. Pleural
Mm.
effusion is not the diagnosis really, it is an expression, right? It
Okay.
is an expression, it is not the
So,
diagnosis. But
yes. So,
if any acute situation happen, I told in my basic classes or the records available in the YouTube, whenever patient present to us with any symptom, many issues are there. One point is there any acuteness of the situation? Any emergency is there? Even whatever the reason of the pleural effusion, you need to manage the patient just to draw the fluid if there is respiratory distress. So without knowing the etiology, you could do it. Your
so I
approach will
just
be
refer to the emergency.
yes for
Okay.
collection of the fluid as well as for further evaluation. But
Okay.
but again, your chamber it is deshouldering. Okay, I am sending to the emergency. You could give oxygen, is not it possible?
Yes, so the ABCD. So when actually in acute case, when we are referring the patient to the emergency, usually we follow the ABCD approach now. So
Which
giving
one
the
is the relevant? Not ABCD, all are required. Whatever the needed, you will do it for the breathing or circulation. What is needed, you could do something. Then send to
yes.
the emergency. Okay.
Okay.
So thanking you, doctor, and hope that sorry again there any new colleague, and Dr. Atia told like any new colleague. Just give me it
Sir,
is yes, please.
sir, I want to add one point.
Why not?
Sir, I want to add one point by seeing the pleural effusion that either it is a bilateral or unilateral, we can narrow down our differentials as well.
Definitely, but that much very expertise not needed in the OSCE doctor. Okay, you
Like
can expand, no
sir,
doubt.
what,
The
like,
bilateral, you could say some etiology. It will be time consuming, and our surrogate will not be up to that much trained. They will discuss about the unilateral or bilateral. Remember it. Whenever you are preparing the OSCE
no,
doctor,
sir,
we
by
have
seeing the X-ray.
this is okay. This is okay, but I believe I understand the expertise will not be that much extended expected by the examiner in the OSCE. Okay,
Okay,
doctor.
sir.
But yes,
Yes.
bilateral, there could be bilateral disease, heart failure, other many things. Yes, but simple disease you can describe, but not any complicated disease better. Common disease better to say. And this is one of the observation from the examiner panel, from the OSCE examiner panel, that our candidates are, especially those who are more advanced, maybe preparing for the MRCP, preparing for PACEs like that, the thought process is a little different. They're telling something rare, uncommon diseases. This is also one of the observation by the examiners. You have to say very common disease first, even bilateral or unilateral. Okay, you can extend if you want, but if you say 3 or 4 differential, that's all. No need to go beyond. Thanking you,
Okay, sir.
doctor. I think we can. This is already the link given. If you new colleague like Dr. Atia, you can immediately join from the chat box in the WhatsApp or AKT, whoever to whom it concerned, rather to say. Now coming to the next patient, Dr. Azra, please Dr. Azra, your voice is
Yes,
very
sir.
clear.
Yes, sir. Okay.
Please,
A
please.
69-year-old man with known
Heart failure with
um,
reduced ejection fraction.
okay, presents with acute dyspnea, orthopnea, and bilateral basal crepitations. Chest X-ray shown. Best immediate management.
So they are not asking you that this is what is the radiologic diagnosis. Because already told heart failure is there, right? So it is not the attention. For OSCE, rather to say again, Dr. Azra, don't mind, I am telling about the OSCE. Some OSCE candidates tell, oh, I diagnosed the case in the X-ray, it was heart failure. But think more today. Intention of OSCE station design is not your diagnostic attitude. Because already diagnosed heart failure by the echocardiogram. But here, management will be the main issue in the OSCE station. So your diagnosis is okay, doesn't mean that you should be happy. Your management should be very authentic, pointed, focused, and life-saving. What will you do now? First of all, OSCE candidate, answer please.
The
We'll
X-ray
give
shows
IV Lasix.
Dr. Anushya, please
To
first.
hospitalize.
One by one, please. Dr. Anushya, please.
Yeah, vitals are not mentioned. We'll give IV Lasix.
Dr. Vital sign not mentioned, but there is some indirect clue. There is a dyspnea, doctor. It is indirectly giving you
Yes,
the
so the
vitals.
patient is in acute heart failure, so we will give IV furosemide.
Okay.
If
Any
he's
more? Tell me as
and
OSCE candidate.
oxygen.
You will give IV
May I
furosemide then.
Yes, sir. May I add, sir, anything?
Why not? But let
Yes.
Dr. Anushya finish first.
Okay, sir.
No more, Dr. Anushya?
And I will, yes, and I will give oxygen.
Oxygen then.
And
Nothing else. Dr. Ati, add any other thing other than these two?
Yeah, sir. First of all, I will make the patient sit the patient upright in position, and then I'll attach high flow oxygen if saturation is less than 94, and then IV loop diuretics like furosemide, as Dr. Anusha mentioned. Then,
Okay.
if patient is hypertensive, as showing heart failure picture by bilateral basal crepitations, along with I can start IV nitrates like GTN infusion as well at the moment.
Nitrate
And
also.
CPAP is
You will add nitrate also here. Okay, but we will be aware of the
Yeah.
blood pressure there. Right.
Yeah,
Okay.
especially.
Dr. Shoaib is to
And
tell
sir,
anything.
CPAP is my
CPAP? That means the ventilation.
CPAP, sir, is my.
It depends upon the
my-
oxygen level, doctor. Better don't go beyond that. Up to this enough because saturation level not given. Dr. Shoaib, to add any new thing?
Now, well, yeah, no, I think it's enough, but I will call the ambulance and
Yes,
arrange
yes, very right. I was waiting to hear this.
yeah,
Dr. Osman, I said this. I will hospitalize the patient.
Hospitalize
Because
means
all
you have
this
to say I will
management,
call.
all this management have to be done in the hospital.
But you could do something in your chamber also. Oxygen.
right.
Even you can give one furosemide injection.
Yeah,
IV.
furosemide, yeah.
IV.
If pressure is very low, you maintain the furosemide with, but with some channel opening rather better.
Yeah, better.
Minimum fluid and the furosemide just to balance it. And oxygen. But calling the ambulance is one of the responsibility of the GP.
Right.
Okay. If you are working in the hospital, you will do many things. But primary thing, arrangement for the shifting of the patient.
Right.
Let's see now option for AKT, Dr. Sharmin and other. Dr. Sharmin.
Sir, seat upright, oxygen if hypoxic, urgent assessment, loop diuretics, and treat precipitant.
Oh, Dr. Atiya, how could you see this answer before? It was not shown anywhere, doctor, before, even with our another colleague.
This is a step-by management of the hospital.
Dr. Osman, I want to say something.
Yes, Dr. Taslima, please.
So Dr. Atiya for the first time, joined this, and Dr. Anushi and Dr. Atiya, both of them are my study partner.
Oh, fantastic.
Oh, excellent,
excellent.
And Dr. Atiya, she is so knowledgeable, So when we discussed, we just say, Dr. Atiya, please say little less.
Thank
We are having 10
you
minutes.
by knowing it very
No,
great,
sir.
doctor. I advise
Sir,
my
I'm
beloved
the
colleague.
second.
My beloved colleague should be in a group always. And I'm very happy to hear from Dr. Taslima. I know Dr. Taslima for a long time, but Dr. Ati is a new introduction to me. But I know Dr. Anuji also before. Anyway, any
Yes,
other colleague from the South Asians and even the Middle East country, we feel very happy to get you here. And Dr. Shoaib is very senior to us. I think the most senior colleague here. So group study is very, very good, and it is expected from you. Very happy to know, Dr. Slimia, you created a group amongst you together, learning. And this is the stepwise learning. And I think it is the best answer we like to open here. Okay. And in the undergraduate information, those who are very junior and the very beginner, there is cardiomegaly, Bett's wing appearance, upper lobe diversion, and Carly's beeline. Upper lobe diversion, Doctor, look at. These upper lobe vessels are more prominent than the lower. It is called upper lobe diversion. It indicates there is a congestion in the pulmonary vasculature. Usually for the gravity, fluid should be more in the down, but upper lobe diversion means more congestion. Otherwise, upper lobe vessels will not be much visible.
Right.
The comparison, okay, X-ray compared here, and the best answer. Thanking you, doctor, to share. So, doctor, next, who will read? Dr. Shoaib is here, though a little late. Can you go with
Yeah,
the
I'm a little late.
please?
Should I read?
Yes, doctor.
Okay, thank you. I just finished my chamber,
Thank you very
Anyway,
much. Thank you
Bismillah.
very much.
Okay, so a 54-year-old obese man has a portable AP chest X-ray taken during an acute visit. The film shown is clinically stable with no heart failure signs. Most important interpretation point.
A technically arranged question, right? Most important interpretation is a non-specific question, rather to say. So I think OSCE candidate can tell much more thing, but very difficult it will be for AKT candidate. Now, if I show the options, then it will be easy for you. But even then, from your intelligence, for your IQ, Dr. Shoaib or other colleague,
Yeah.
what do you like to say about the interpretation of the X-ray here? That is a philosophical question.
Yeah, it looks to be boat-shaped heart.
Boot-shaped. Boot-shaped is the pediatric group. Is the feature telling is a pediatric X-ray? Look at the bones and others.
No.
If no, why you are thinking boot-shaped?
No, I think
age is 54 already.
Age is 54, yeah.
So there may be some acuteness for that AP X-ray taken, right? Not the PA.
Yeah.
We tell it by
Acute.
sometime that what is that? Portable X-ray. Usually resolution will be less. Technical message is there.
Right.
And technically there might be some cardiomegaly like appearance in the chest X-ray.
I mean, boat-shaped heart, I mean there is a cardiomegaly.
An elevated diaphragm could be there because it is an AP X-ray. Okay.
Sir, trachea is slightly shifted to the right.
Right. If we can think of it, could be relevant because trachea will usually not be shifted due to the AP view, right? Trachea will be in the middle.
Yeah.
But here trachea is shifted, right? But
Shifted.
if patient is moving on the bed, Dr. Layton, very restless, it could happen. Many technical error could be there. Even then, our observation trachea is shifted to the right.
Right.
Could there be any reason of tracheal shifting?
There is no equal distance from the sternal head.
Oh, a very intelligent eyes are here. Dr. Adnan is telling, yes, from there, clavicle is there. It is not equidistant. I uttered before. I think you know before me also, I believe. It could be. It could be. So you mean that tracheal shifting is not clinically more significant also. So what is the significant here?
Enlarged heart tissue may be due to APBU and
Okay. But there is something acute visit, but patient is clinically stable. Again, acute visit is there. Maybe doctor, I need to see you. What is the reason not mentioned here? But obesity is there. But obesity can cause breathlessness, right?
Yes, sir.
Obesity can cause breathlessness. If it is a lying position, it will create the more problem. Let's see the option without wasting the time. Choose your best answer. Choose your best answer.
C.
I think C.
C. Recognize AP. That is AP view. Poor inspiration may falsely magnify heart and basal markings. That means a technical message for you. Dr. Litton, to tell any additional?
Yes, sir. In FEVO, mediastinal widening is commonly differentiated from posterior PA.
Okay, PA is not possible, already AP done. How you plan your management plan? If you want to select the D, start diuretics immediately. Before that, what will you do clinically? Already you have done
The
though.
patient is clinically stable and no
Stable.
hypertension
Yes,
signs.
yes. If you want to elicit a
We
sign
put
there,
up start
Dr.
diuretic.
Litton, if you want to elicit a very important sign in the patient, blood pressure is okay, but
JVP?
Sir,
ABP is a long
JPP,
standing finding,
Basal
doctor.
cavitation by basal
Yes, yes,
cavitation.
Dr. Adnan is very right. Basal crepitation, basal crepitation. It will guide you for the management. This is expected from OSCE candidate doctor nowadays, because OSCE preparing or creating specialist. Don't think that you are like AKT candidate. Your thought process should be expanded. I think C could be the answer here. Let's see now. So identify that it could be portable X-ray by looking there. And usually some marking will be there also, right, Dr. Leighton? AP or the
yes, sir.
lying position. They could, some marking usually technician could do. But you are looking such X-ray, but clinically almost stable. Suspect it is an AP view, though it is not given. This is another clue. Okay. So portable is there. Already mentioned portable. Portable, right. So answer will be recognize this is a technically important X-ray as it is an AP view. So maybe some problem of breathlessness for the lying down by the obese people. Assure, right? Assure. In the technical quality, the RIP, doctor, I will not elaborate here. Again, requesting you to go to the YouTube, any new colleague here. For the tech, it is our, the headline was technical adequacy of the chest X-ray, available in the YouTube, doctor. It is a must for your practice. So may harm. This is something option, doctor. Why this is not correct answer already mentioned here. Okay. And last one. Dr. Shoaib bhai, please. Aisha Mubashir. I remember your name, Dr. Aisha. Are you not free, doctor? Otherwise, Dr. Shoaib bhai, please can continue. The next patient. Dr. Shoaib, please.
Okay. A 63-year-old man presents with sudden severe epigastric pain and rigid abdomen. Erect chest X-ray shown. Most appropriate diagnosis / management.
What will you do now in a
Yes,
GP
under the
position?
diaphragm.
Under the diaphragm. So diagnosis is very clear. It is undergraduate answer. Sorry to say that if I say, but what will you do now?
Yeah. So again, I will arrange an ambulance to send the patient to
Ambulance?
emergency.
Oh, you are thinking something serious. Epigastric pain.
Yeah.
Epigastric pain
There
is
may be some perforation.
yes,
Yeah.
perforation of
Viscous perforation.
Perforated peptic
gastric
ulcer.
perforation, because epigastric pain is there, and rigid
And
abdomen
rigidity there.
means rigid abdomen means
Peritonitis.
Yeah,
peritonitis.
Peritoneum.
Yes.
Signs of peritoneum.
If you can remember in even our module also, approach to the acute abdomen. First thing is identify, is there peritonitis or not? Whatever the
Right.
cause of the perforation. If
Right.
peritonitis, what is the clue clinically? Dr. Shoaib can tell.
Yeah. Yeah. So
You are looking the
see
patient on the bed, acute abdomen.
yeah,
Without touching the patient also, you could have an idea there is a peritonitis. By how?
looking at the abdomen, it will be both like rigidity.
No, without touching. I'm telling by only looking.
He'll be tachypneic.
Indirect telling. Dr. Adnan and other colleague.
Yes, sir. Patient maybe stand still, not
Yes,
moving.
yes. Patient will be
Not
standing
moving.
still,
Yeah.
not
Yeah.
moving. It is
Yes.
peritonitis. But
Yeah.
if it is cholecystitis, pancreatitis, or other abdominal crisis, patient will be moving on the bed.
Right.
Very simple
Rolling in the
clue.
bed.
Very simple clue. Then you confirm your understanding by touching the abdomen. Clear,
Right.
Dr. Shobhai?
Yeah, yeah.
My technical question, especially the ASCII candidate and Litton and other colleague also. In our abdominal crisis, what X-ray usually we advise? Is X-ray of chest or abdomen?
Abdomen, sir.
Abdomen, sir.
But a standard X-ray will be chest X-ray.
Direct posture.
But if you think it could be other than peptic ulcer disease, or there may not be air under the diaphragm, how have an idea that air under the diaphragm, just loss of the liver dullness, right?
Right.
Just ruminate your third year, fourth year knowledge.
Yeah,
If we suspect loss of liver dullness, especially in the right side, not in the left is separate thing. In the right side is the liver. It could be due to COPD also, the loss of the liver dullness. But clinically, you are not suspecting COPD, but acute abdomen with the loss of liver dullness, think of air under the diaphragm. In that situation, your X-ray will not be abdomen. But in our tradition, I can remember also in my learning time, I don't know what about from Sri Lanka, other country colleagues, we are advising the abdominal X-ray in erect posture. Am I true, Dr. Litton and other?
Yeah.
Dr. Shobhai
Yes,
can tell
sir.
the senior colleague. But ideally, it is found, I can remember even 1 millimeter air or 1.5 millimeter air can be visible by the X-ray chest.
Okay.
Remember it.
Right.
So intelligent clinician can do the chest X-ray, but in the abdomen, erect abdomen could be important if I suspect intestinal obstruction. Okay, somehow.
Right.
Yes, sir.
How identify intestinal obstruction? If there is what is called peristaltic movement is there. If peristaltic movement is there, then better do chest X-ray or abdominal X-ray.
Chest X-ray.
Abdominal X-ray, doctor.
Abdominal
Because
X-ray.
you are suspecting intestinal obstruction primarily. There could be secondary paralytic ileas also from there. It is true. But there is no peritonitis. Okay, only features of the acute abdomen, and you are looking in the inspection, there is a peristaltic movement. So at that situation, we can advise for the abdominal X-ray.
Abdominal.
If we suspect underlying abdomen could be due to the stone disease, then we can advise abdominal X-ray, preferably KUB, right? Like that.
Right.
But only we are suspecting it could be ruptured stomach or perforated peptic ulcer disease. You know your patient for a long time for the peptic ulcer disease in the Ramadan time, and he's a Muslim. What will you suspect? Perforated peptic ulcer. And our X-ray attitude will be actually like this. Now, the diagnosis is perforated, viscous, and you refer urgently because there is a features of because of peritonism or peritonitis.
Right.
Otherwise, patient will die. This is your GP responsibility. Last picture for you, doctor. Already we discussed our 10 patient today. Which panel we discussed today? Any colleague, please? Right side or left side? Did we discuss today? Which one? Left side or right side?
Left side.
Mostly left side.
Mostly left side or mostly right
Yes.
side? Mostly left side, but not all. What we didn't discuss from the left side? Maybe miliary tuberculosis,
Miliary TB,
COPD,
bronchiectasis,
atelectasis indirectly we discussed by the middle lobe collapse.
collapse. Yes.
Fibrosis we didn't discuss. From the right side, any disease did we discuss? Maybe
Congestive
no.
heart failure.
Congestive heart failure.
Maybe no. Maybe congestive cardiac failure, yes. But mostly we didn't discuss. It means actually I am showing to you from the general practice point of view or in general, these are the X-ray you must know about. If I continue this thing, it will take again 1 hour, 2 hour. It will not be practical. But I'm very happy that you may stay if you have time. But I need to finish also for you. You need to know about, if possible, We can sit with you another day with some other X-rays if possible. But this is the today open the door for you, how to read the X-ray and revise your X-ray. And hopefully it will be very beneficial for you. In any other day, we will invite you for the X-ray doctor. And then now, sorry, that is we discussed already. And this is some X-ray learning resources are there in the YouTube. I think if you pick up the YouTube link from our group, anybody can get it. So first priority is to join the group. Already I send the group link, WhatsApp group. And then you need to know about the musculoskeletal X-ray. These are the things. And it is already surveyed, research done. What are the common X-rays in our general practice as well as important for your AKT and the OSCE? These are the things. From the musculoskeletal disease in the right side, ENT, minimum 5. You can extend, but it is mandatory. You must know about it. Okay. So all of the X-ray, this is your part of your learning, including some abdominal. And I think recently past AKT colleague can tell also about from there. I think I can remember one intestinal obstruction X-ray was there, right? Dr. Shoaib and other. Intestinal obstruction, maybe valvulic conjunctivitis like this. X-ray was there, maybe intestinal.
Sir, that was sigmoid volvulus.
Oh, that means it was the, what is that?
Sigmoid volvulus.
The coffee bean appearance.
Yeah, sigmoid valvulus.
Yes.
Right,
Sigmoid
right,
valve, right. Intestinal obstruction. There is a large bowel obstruction.
Sir,
Large bowel obstruction.
yes.
So
Right.
you must know it about. Okay, doctor. And for
Right.
OSCE also. For OSCE also same. So those who passed AKT, don't close your books. Okay? Don't close your
No.
books. Don't close
No,
your
no, no.
books.
So, doctor, in OSCE, do they give X-rays from musculoskeletal as well?
Yes, doctor, nowadays,
Mhm.
especially the fractures. Okay? Fractures
Yes.
and others. Don't forget it. Somebody
Okay.
said.
In chest
Sir, one
X-ray,
question.
Sorry, doctor?
in chest X-ray, do they ask us to pick up any rib fractures or trauma-related X-rays?
Trauma, if it's a gross trauma could be there, doctor. They will not make you puzzle really. Which is gross there, don't miss it. Okay? Don't miss it. But what
Sir, one question.
please, doctor. Any slide should I open, Dr. Litton?
Sure, sir, sure.
Which one? Which one do you like to discuss about?
Sir, approximately how much X-ray, ECG, or pictorials from dermatology
It is not
should be
fixed,
given
doctor.
in the
It is not fixed. It is not fixed. X-ray usually will be 2 station, not more than that. And ECG also same, not more than 2 usually in the OSCE station, because only limited stations are there. Okay.
is there any, sir, CT, MRI, or
No, uncommon.
anything else?
No, till
Till
now.
now, no.
No. I request all of you, Dr. Litton and other, those who passed recently, go with some introductory sessions recorded available in the YouTube also, okay? Not in the module only. We discussed radiology, X-ray, and others also, okay? It will
Okay,
enlighten and enlarge your understanding. CT we didn't discuss also. We discuss about the X-ray of the ENT. Okay, there are some radiology. I already shown you, doctor. Look at Litton, that one. These are the links. If you don't have, just request in the group. I can attach there some common discussion. And AKT also you can remember, maybe not more than 2 ECG. Okay, more than 2 ECG. So I think after finishing, we congratulate to all of the colleagues who have passed and inviting other new colleagues who are preparing with this work module. And if you have time, you can join with us. Those who passed recently were very happy by the mercy of Almighty. I think till now I received the message more than 10 colleagues today. I think it will be more also from Bangladesh, India, Pakistan, Sri Lanka, maybe some of you from the Middle East also. So it is a developing. updating module for you. Those who are new, try to join with us. And any colleague doctor, this is a privilege to give you to register, and this is a little discount already declared for us. And we give a puzzle for you, or not puzzle, you make a snapshot, doctor, to get this benefit. Reduction. Huh? If you are there here, make a snapshot and provide to us. You will get the discount. And this is this thing. And now I think a little time for the colleagues, 1 or 2 minutes. I think I requested to tell later on about the AKT expression. Maybe 1 to 3 minutes actually. What your suggestion for the new colleagues for preparation? Who will tell? Dr. Litton, please, I think. Though we will sit with you in a special arrangement we will make within few days, but very briefly, not more than 1 minute, Dr. Litton, for the AKT.
Okay, sir. Okay, sir. Thank you for giving me the time to tell something regarding the AKT. First of all, I observe, though I took preparation just only 3 to 4 months maximum, I decided to sit for MRCGP examination at the start of this year, January, and
Dr.
initially
Litton, can you improve your voice? Sorry to say, it's not much
sir,
audible smoothly.
I'm traveling. I'm traveling from one place to
Okay,
another
understand.
place
Sorry to
right
finish
now.
early. Sorry, better to finish early, doctor.
Oh, okay. Sir, your course is really helpful to me personally, and I didn't read anything except your course module.
Thank you, doctor.
It's,
That's all. I think
it's
we
so-
can hear more from you in a separate session, as you are in a traveling. Better not to be troubled much. Thank you, Dr. Leighton.
yes.
And actually, we need to close also today. Near about more than 1 hour we passed. I think Dr. Shoaib can tell. I think he is free to say. Dr.
Right.
Shoaib,
Thank you very much, Dr. Usman.
please.
So first of all, I must thank the Almighty Allah Subhanahu wa Taala when I decided that whatever my experience and whatever, I didn't have any recognized degree which people used to judge a doctor. Okay, so when I decided to appear in exam, so I was looking for that. And fortunately, from the Facebook, I got Dr. Osman's details, his WhatsApp number. And my time was not much because I'm a busy practitioner, 8 hours duty, six days a week. So I thought, okay, then I contacted Dr. Osman, and he said some free sessions. So I did it, and I liked it. And as Dr. Litton was telling, that I didn't go I didn't read any book or anything except Dr. Usman's module. Alhamdulillah, I could finish in a time, and I also sat for the 2 mock exam. So I think anyone in the recent future wants to really prepare for the exam. Now it's not a good idea to read a book, okay? So the
I agree.
discussion,
I agree. Really, this is a
yeah,
comment, though a little bit harsh.
yeah,
Don't go with the book.
yeah.
Actually, you have gone through the book earlier
Yeah,
in your
yeah,
life.
definitely. But for the exam for 6 months, 4 months preparation, it will be enough, I think, because the lively discussion what Dr. Usman is doing is very clear, and anyone can follow that one. And plus a little bit 1 or 2 hours or minimum 2-3 hours daily self practicing, that will, I think, make you success, inshallah.
Thank you, Dr.
So
Shoaib, for
thank
your
you,
good words.
Dr. Usman. You're really a teacher. Okay. When
May
I was
Allah, may
talking,
Almighty accept it. I'm not teacher. I'm just
Alhamdulillah, Alhamdulillah. When I
facilitator.
was talking to you, when you rang me, there's a patient in front of me. So I said that, Alhamdulillah, you're very fortunate, my patient. I attended for an exam, and I was talking to my teacher. He said he's younger than you because he listened your voice. Okay, so yes, he's younger than me, but he's my teacher. Alhamdulillah. Thank
May
you, Dr.
Almighty
Usman.
accept that. Dr. Taslima
Thank
could
you.
say anything. You open the mic. Otherwise, we can finish. But I have some few words for OSCE preparation also after that. Dr.
Sure.
Taslima,
Yes, sir.
tell anything, please.
So I was just listening Dr. Shoaib's conversation, and she is the most senior colleague of mine. But
Not
I
only
think
of you, all together here, of all
yes,
candidates.
but he's the most energetic and most youngest. I will tell that, like, and in this age he attempted and he cleared.
Yes.
So congratulations again, Dr. Shoaib. And Dr. Osman, I have gone through your module during my AKT time,
Right.
and you gave it to me totally free.
It is our pleasure,
And
doctor. We could do at the
yes,
time. Yes.
and it's the contents were so rich because at that time I follow your module, and it was so vast and it's so rich that actually if anyone follow your module, he don't require anything else. This is more than enough to pass, to clear
May
the
Allah
AKT.
help, doctor. I think thank you, Dr. Taslima.
Yes.
Again, we said before also. So for the AKT, those who newly passed, our request and message to you, we would plan for you together and invite other new colleague to sit. You will guide again detail later on. Maybe after, maybe on the Thursday or Friday, probable date by the mercy of Almighty. We will invite you. If possible, you can join with us, and with the good wishes for you again. Those who are preparing again for AKT past candidates and now appearing the exam for the OSCE, if any colleague, this is the practice session now ongoing, Sunday and Thursday. Already we have started with the first class the last Tuesday, and records available. Those who want to join with us, you can communicate with us personally. Doctor will guide you further how to overcome it. So lastly, this is the beginners module as ASCII, okay? Those who are not appearing ASCII immediately, learn with us. Module again ready for you, but it is not a completed module to appear the exam. After finishing this, you need to come to the practice session. Without doing this, you will be very immature. Your practice session will not be fruitful. So that is up to this doctor, and this is a commercial to say that 99 USD for the Chennai exam. I think this is the ending, doctor, for your patient hearing and participation. We are very happy to see you here. Thank you very much to join with us,
Thank you,
and
Dr.
see you
Usman. Thank
in the
you.
next
Thank you.
time, next day, in the same time.
Inshallah.
May Almighty help, doctor. All the best.
Thank you.
All the
Thank
best.
you.
Thank you, sir.
Thank
Look
you so
your
much.
eyes in the group for the further notification, doctor.
Inshallah. Inshallah. Thank you very much. Good night.
Okay, doctor.
Allah
Bye-bye.
Hafiz.